So, Seth and Virginia, let's go ahead and look at this patient who's a 43-year-old premenopausal woman. She had a mastectomy, and her biopsy had shown a 6 centimeter invasive lobular cancer, ER 80%, PR 10%, HER2 IHC 0, and really very slow growing, Ki67 10% grade 2. But at mastectomy, she did have 3 of 3 positive central lymph nodes. And then she went on to have an axillary lymph node dissection, which found 2 additional axillary lymph nodes. So she actually had 5 of 15 positive nodes. So this is a dilemma because she's got this indolent type disease, but she's got 5 nodes and she is premenopausal. So would you send a genomic signature? Is this a patient you're on the fence about giving chemotherapy to? So if she came back with a low genomic score, you wouldn't give her chemotherapy? And let's look at a couple of different scenarios. Let's see that on the one hand, we find out she's germline BRCA1/2 a negative, or on the other hand, she is germline BRCA mutation positive. So Seth, how about you? Is this a patient you'd consider a genomic signature for?
Thanks, Joyce. I think this is a challenging situation because you can feel yourself being a little bit pulled in both directions. On the one hand, we know that these slower growing lobular breast cancers might not respond as robustly to chemotherapy. On the other hand, she's a premenopausal patient who would really be out of bounds. For example, on the Taylor X study, she has a T3 tumor with N2 disease. And so we feel compelled to offer cytotoxic chemotherapy, knowing that the biology of her disease may not be as sensitive. But at the same time, if you were to forgo chemotherapy, I think it would be potentially inappropriate based on the inclusion criteria for those studies. So in my opinion, I would not get for example, an oncotype, the first rule in medical school that's hard to integrate is don't get a test if it's not going to change your behavior. And I think in this case, it wouldn't change my behavior. I would feel compelled to offer her treatment. But as you were alluding to a moment ago, I think giving her chemo would be important, but most important will be getting her optimal extended duration anti-estrogen therapy with appropriate targeted therapy that I'm sure we'll talk about in a moment.
Thank you. Thanks a lot, Seth. Let me just ask you, you're going to give her chemo, it sounds like. What chemo would you give her?
Here's another one that I think the magnitude of benefit for anthracycline here is somewhat difficult to appreciate, but she does have 5 positive lymph nodes with a large tumor, and I think I would discuss dose dense ACT with her. In my gut, I'm sort of thinking that the absolute magnitude of the Adriamycin is hard to pin down here, but she does have N2 disease. I think if she had N1 disease, fewer positive lymph nodes, I might consider foregoing the anthracycline. But given her young age and the extent of her axillary involvement, I would probably offer her what I thought was the sort of most aggressive cytotoxic chemotherapy.
Thanks. Thank you, Seth. How about you, Virginia? Would you consider a genomic score like a mammoth print? And I know, of course, you guys are doing the SWOG 2206 trial. So how would you incorporate a genomic score into her management?
So yeah, so if she came to me pre-surgical, then I would consider sending the mammogram to see if she's eligible for the S2206. But if she comes to me post-operatively, then as Seth said, I would feel compelled to give her chemotherapy. She's premenopausal, a young premenopausal patient with 5 positive lymph nodes. So I would definitely give her chemotherapy. Now, if there were reasons to try to avoid ACT, which is what I would also do, I'd be thinking of giving TC, but for 6 cycles instead of 4, because this is the data that we have. And if you look at how easy it is to give TC times 6, it's not really very easy. It causes a lot of neuropathy, a lot of arthralgias. So as far as acute adverse events, I really don't think that ACT is any worse than TC6.
Yeah. And with 6 of docetaxel at 75, you run that 1 to 2% risk of permanent alopecia. I've seen it with like the preoperative TCHP over the years. We used to see it a lot with 100 per meter of docetaxel times 4, which we never use. anymore, but I've seen it with TAC times 6, you know. And so it's a consideration. We got to tell patients, you know, about that, and see if they can possibly scalp cool just to preserve their hair follicles, so it would come back in. I agree with you guys. I would be looking at an ACT like regimen. I think we all will be happy when we have the results of the offset trial. And we, you know, and that's of course 1 to 3 nodes. It's not 4 or more, but it's a high risk node negative and 1 to 3 nodes. And the 21 gene recurrence score, if it's 25 or under, then they get randomized to chemo, no chemo, in addition to optimal endocrine therapy with an LHRH agonist and a CDK4/6 inhibitor. And I think I always tell patients that doctors are kind of betting that the chemotherapy won't add in the context of optimal endocrine therapy. Otherwise, they'd never randomize half of their patients to not get something if they thought it was going to work for them. You know what I mean? So, but that's going to be a long time coming. The offset trial. I think we'll probably extrapolate to the 4 more nodes once we have the results of the offset trial, don't you think? I mean, if it comes back that chemo doesn't add, you know, for the 1 to 3 nodes, I can't imagine it would add to 4 or 5 positive nodes, you know. So we're going to give this patient adjuvant ACT, and then she's going to get radiation therapy, post-mastectomy radiation therapy, and IV zoledronic acid. I'm just curious what your choice of endocrine therapy would be. CDK4/6 inhibitor, and what if she had a BRCA mutation? What do you think, Virginia?
So if she's BRCA negative, I think it's clear. I would definitely do ovarian suppression, an aromatase inhibitor, and a CDK4/6 inhibitor. And in this case, because she's eligible for both CDK4/6 inhibitors, I would look at the fact that Monarchy is more mature as far as a trial. It has an overall survival benefit. So I would favor that approach, at least to start, and assuming the patient tolerates it. If she's BRCA positive, she's eligible for a PARP inhibitor. She's eligible for olaparib. So here we need to kind of think about, do we give olaparib? Do we give the CDK4/6 inhibitor? What do we do? And there's some nice data generated from Memorial Sloan Kettering that these patients that have germline BRCA2 mutations, because mostly they're BRCA2, they seem to have, their tumors seem to be relatively resistant to CDK4/6 inhibitors. And so I would definitely give the olaparib first and complete a year. After I was done with the olaparib, I could consider starting the CDK4/6 inhibitor and doing 2 or 3 years, depending on which one we gave. But I think the biggest part of my treatment would be the PARP inhibitor.
Yeah, thank you. But you'd consider sequencing with, and I guess you know, as I was thinking, I've not been sending the primary cancer for NGS. I think they found out that, you know, the RB gene is close by on the chromosome to BRCA2, and as the cancer loses that second copy of BRCA2, that they can lose RB, and when you lose RB, the CDK4/6 inhibitors don't work. But and that was a super cool observation, you know, like you said. But I've not been sending the tissue, you know, for NGS. I have for these very high risk patients. I give them the year of olaparib, and I do generally come in with the 2 years of abemaciclib afterwards. I figure, gosh, everything we can possibly do for these patients. But I haven't been sending for NGS, you know, to see. And I don't, yeah, but it should have been something in the primary cancer as opposed to a resistance. It would not be a resistance thing. So we might find it in the primary. It'd be nice to have more data on that. You know what I mean? So we could actually help, you know, figure out what to do. How about you, Seth? What would you do with her? You know, she's BRCA negative, BRCA positive.
I agree completely with the great points that Virginia made, and first, for a BRCA negative situation, we certainly want to optimize endocrine therapy with ovarian suppression and extended duration treatment on an AI. For these lobular ER positive breast cancers, as we were just alluding to, I think this is the backbone of their risk reduction over the long term. And she would meet criteria, as we just discussed, for both. And I also agree, I would favor Monarchy, given the long duration of follow-up off drug, as well as now the overall survival benefit. If she were both BRCA and would meet criteria for adjuvant CDK. I agree completely, and I think the point Virginia made is really important one that's underappreciated. That we have some emerging data from that nice study about the impact of germline BRCA and response to CDK. Now, even before we had that data, most of us were paradoxically kind of going for the PARP inhibitor because we had survival data for the PARP inhibitor first before we had survival data for monarchE. So we would do, if a patient was eligible for both, we would often try to give the PARP inhibitor first because we had survival data. It was a shorter duration of therapy, and then get on to the CDK. Now, interestingly, when you look at the magnitude of the difference on the order of 2 to 3% survival improvement, with a few years of follow-up, I think you could make that argument both ways. But the point that you were both discussing about the impact of BRCA on CDK would also make me favor giving the PARP inhibitor first. We certainly would not give these together due to lack of safety data and risk of compound toxicity, particularly cytopenia. And Joyce, the point you were just bringing up about the RB mutations is also very interesting. We know that double hits in RB are relatively rare in the metastatic setting for resistance to CDK inhibitors. And often the second hit is difficult to detect on sequencing. It could be like a loss of heterozygosity. So you'll have one hit and then you'll lose the second copy, but it may not be from a point mutation. It may be just that you lose the copy and you don't pick it up as readily on circulating tumor DNA or even on solid biopsy because there's heterogeneity amongst the different sites. So when we have the BRCA mutation, we have this interesting biology in terms of RB. It may be difficult to detect, especially in the early stage setting. But we're learning a lot about this in the metastatic setting. We're also learning about non-genomic ways that RB can be disrupted. We're looking at epigenetic profiling and other things. So my opinion is that the concept of dual hits in RB for resistance to CDK being rare on the order of 5 to 10%, we may be missing a lot of this in ways that are not detectable from conventional circulating tumor DNA. And how that feeds into resistance to adjuvant CDK inhibitors and how that may inform our approach in the metastatic setting is a very interesting question, and I think will be a topic of a lot of interesting translational work in the next few years.